Hello doctors, welcome to yet another episode of our Dialogue web series. So today we are going to talk about a very important topic in obstetrics, that is the early pregnancy scan, and that too ultrasound tips for each and every obstetrician, which would be very helpful in your day-to-day practice. The first thing about early pregnancy, all of us know, most of us do our early pregnancy scans as well. Dating scan, when is the ideal time? So when we see when is the ideal time, we obviously want to locate the sac. We want to know whether it's intrauterine or extrauterine. But apart from that, the ideal time for a low risk gravida or say a low risk preemie, or where they do not have much of risk factors which has been seen earlier, then the ideal time would be anywhere between 7 to 9 weeks of pregnancy, because after 7 weeks is when the CRL becomes a lot measurable, that is above 1 to 1.5 centimeters, and during that point of time we will be able to measure the CRL and we can confidently adjust or give them a corrected date based on the ultrasound, that is an ultrasound EDT. So if you ask me, for a low risk primary gravida or a low risk mother to do a dating scan, somewhere between 7 or 8 weeks should be an ideal time. That's point number one. Chronology of events, all of us know, starting right from the appearance of the gestational sac. So as you can see over here, the gestational sac, which is seen right in middle of the cavity with a good amount of decidual reaction, where the pointer is showing is the proper location of the gestational sac as a single intrauterine gestational sac, where you also have to see not just the location, to the amount of decidual reaction, that's the bright echogenic thing surrounding the sac, and number 3, the regularity of the sac margins. All these 3 things are very important when you perform an early pregnancy scan as early as 4 to 5 weeks. Followed from the sac, then the next thing what you see along the sac, you see the yolk sac. Along with that, connected to the yolk sac is the vitelline duct, and here you see a larger structure or a membrane which is called the amniotic membrane. So invariably anywhere between around 5 to 6 weeks, these are the structures which you would see. Beyond that, what would you see? Yes, a yolk sac. After that is the embryo. So a measurable embryo, as I said, starts from probably anywhere between at the end of 6 weeks. So 6 weeks you'll be able to see a fetal pole, and beyond 7 to 8 weeks it becomes more than 1 to 1.5 centimeters. So these are the structures which you need to see and differentiate in the early pregnancy scan. As I told you, when do you call it as a true gestational sac? These points are extremely important. As I told you one point earlier in my first slide, the sac, the regularity of the sac, because apart from that, we will not be able to tell anything about the pregnancy during the 4 weeks. So you see the location of the sac, decidual reaction, and the regularity. So if you can see here, this sac is pretty more irregular, and when compared to this sac where it is slightly elongated. So what is called as the pseudo gestational sac, where you don't find good amount of decidual reaction in this, whereas this sac over here doesn't seem to be a good oval shaped or a circular gestational sac when you compare to this sac, where you can see a good round elliptical or nice well rounded circular structure surrounded by good amount of echogenicity, which is a decidual reaction located right in the middle of the cavity. So this is supposed to be a true sac when compared to the other two above. So apart from that, the next question would be, okay, so when do we call it as an early pregnancy failure? Because most of us do repeat our early pregnancy scan after 1 week or 10 days or 15 days based on the pregnancy symptoms, isn't it? So the criteria which we use, that is ACOG criteria or even ISHO criteria, which is used to define early pregnancy failure, would be an empty gestational sac. That's the first thing, an empty gestational sac, or the MSD, that means a mean sac diameter of more than 25 millimeter, all the sac size, without a measurable embryo. You could definitely call it as an early pregnancy failure. Number 2, the second point is when you find a gestational sac and a yolk sac, but you are not able to see a fetal pole for more than 7 days, or again call them after 10 to 15 days and still you are not able to see a fetal pole, it is just a sac and a yolk sac, then you are definitely eligible to call it as an early pregnancy failure. You have seen a sac, a yolk sac and a measurable fetal pole, but the fetal pole is above 7 millimeter, but yet you're not able to see a cardiac activity. Even then you can call it as an early pregnancy failure. I think Beyond that, during early pregnancy, the next thing which we commonly nowadays beyond ART, what we are seeing are multiple pregnancies. And multiple pregnancies, the ideal time to demonstrate the chorionicity is during the first trimester and also during the NT scan time. So the terminology of twins should be removed. No ultrasound sonologist or a fetal medicine consultant, even as an obstetrician, should use the word only twins. It should always be with the possibility of a chorionicity or an amnionicity. So the reporting format should not just be twin pregnancy. It has to be either a dichorionic diamniotic twin or a monochorionic diamniotic twin or a monochorionic monoamniotic twin. So it basically, the difference between in early pregnancy is you will be able to see two sacs different or slightly separated apart in a DCDA pregnancy, and this lambda sign is very typical of a dichorionic diamniotic ring because you have four membranes in between the two fetuses, whereas here this is a T sign which is a monochorionic diamniotic T sign where there are only two amniotic sac where there is only a single chorion. So this demonstrates a T sign which is a monochorionic diamniotic twin. So the position of fetus is also extremely important because before fetal reduction or in any IVF or ART conceptions, we do position one, we do make sure that the fetuses are labeled in the anti-clockwise direction so that we don't remeasure the same fetuses again. I think in this video so far we have seen about what are the ultrasound criteria for to diagnose early pregnancy failure. Number 2, how to differentiate a DCD8 from an MCD8 twin as early as in the first trimester. And last but not the least, we're going to talk about ectopic versus corpus luteal cyst, because this is where we get plenty of second opinions, because most of us, we tend to get scared when we want to report an ectopic pregnancy. The most common differential diagnosis which we get for ectopic is corpus luteal cyst. So how do we differentiate between ectopic pregnancy and a corpus luteal cyst? There are clinching features are, yes, there will be a cystic structure, could be a cyst or even a sac, but then what happens is that in a corpus luteal cyst, the cyst will be inside the margin of the ovary. So if you can see here, there is a cystic lesion. This also will have peripheral vascularity. Ectopic gestation also will have peripheral vascularity, but the corpus luteal cyst will be within the substance of the ovary with peripheral vascularity and will not have any structures like yolk sac or a fetal pole inside it. Whereas in an ectopic gestation, you should be able to significantly differentiate the ovary from that of the adnexal mass. Right, if you can see here, this is the ovary which is seen separately and the adnexal mass separately. So you can actually make out that the adnexal mass is separately seen away from the ovary. This is the clinching diagnosis in ectopic versus corpus luteal cyst. I think this video, a short video on early pregnancy ultrasound tips, would have been very useful to all of you. Do share this video with all the other obstetricians, fellow obstetricians and colleagues. See you all soon in our upcoming video series, dialogue web series, in yet another episode. Until then, take care. Bye-bye.